And welcome back to the implementation track at Eyes on Dry Eye 2022. I'm Dr. Damon Durker. I'm here live in Indianapolis. I'm the Director of Optometric Services at Eye Surgeons of Indiana. I will be your host all weekend. I'm very excited to introduce our next session here. This is a non-CE track. Remember, this is a tell it like it is. So we want to see lots of questions, lots of engagement from our audience. Our topic is accelerating growth of in-office dry eye disease procedures. We have Dr. Mina Farahani, Dr. Tom Chester. Welcome to Eyes on Dry Eye, Mina and Tom.
Thank you so much, Damon. Thank you. It's really an honor to be here, to be in reaching out to so many people across not only the country, but even around the world. So thank you so much for tuning in. We really want to make this a very practical, hands-on session, give you some pointers of things that have worked in my practice and in Tom's practice as well. So without further ado, we're going to dive right in. So our objectives, we're going to really share our approach to dry eye treatment. And I find it personally very helpful to have a script to do this, just to explain things in an organized way to my patients. So we'll go over our scripts as well for that and how to set realistic expectations, not only for dry eye treatments, but especially really for these procedures that we're incorporating into our practices. We'll talk about how we identify and screen patients for these various dry eye treatments, how we incorporate diagnostics into our dry eye exam so that we tailor these procedures for the best, most suitable candidates for them. And we'll address some of the things that could be a little tougher to talk about, like objections regarding the treatment itself or pricing concerns that many of us, a lot of these questions that just come up practically day to day as well. So we definitely want to give you some advice on how to tackle those tough questions. And then we'll discuss how we improve compliance with dry eye treatments, can help improve compliance with these procedures as well. And then we'll talk about how some tips basically to help grow your dry eye practice both internally and externally. So first, we'd like to just start off with a little bit of an introduction to our practices. So Tom, can you go ahead and share what your practice is like?
Absolutely. And I want to reiterate, thank you, Damon, for the opportunity to be here and Eyes on Dry Eye as well. I mean, this is a great opportunity. And so I look forward to kind of sharing some of our pearls. But in my practice, it's a multidisciplinary ophthalmology group. We have large multi-specialty. We have about 14 locations with 3 ambulatory surgery centers. We have 35 providers that range from oculoplastics to retina specialists to optometrists to all different specialties, from specialty contact lenses to myself, dry eyes. We cover most area, pediatrics, all those, and we are a pretty strong referral center in the area. In addition to our 35 providers, we work with over 100 providers in a large geographical area as well. How about you, Mina? What's your practice like?
Yeah, so my practice itself is pretty similar. I have a different role in it, but I'm at Ophthalmic Consultants of Boston, which is another large multi-specialty private practice in the Boston area. We now have 18 locations for ASCs. Our practice recently merged with iHealth Services, so we expanded within the past year. We actually have 72 providers now in ophthalmology and optometry, and are also a referral center. I personally am cornea external disease trained, so I do cataract surgery, corneal surgery, bit of refractive as well, and then really am creating a niche in the dry eye patient population too.
Right. Excellent. Yeah. Even though we try and be niche with dry eyes, I mean, we have a tendency to see everything. And actually, a lot of those things relate to dry eyes. I know we talk in glaucoma, a lot of those glaucoma patients end up with, dry eyes based on medications. And so one of the things that I'd like to ask you, Mina, is how do you approach dry eye? We just mentioned glaucoma patients may have it, surgery patients, perioperatively. How do you approach dry eye to your patients?
Yeah, that's a great question, Tom. So I think that patient education is so important, and you really need some of that share time up front. If a patient doesn't know why you're having them do this homework or this routine every single day, compliance is going to drop off. So I think some time up front, explaining, using diagrams and tools can be really helpful. So practically what I do for my patients, I explain or try to simplify dry eye for them. So I often say we took my script, the thing that I can rattle off like in my sleep because I say it so many times a day. is that we have two main things in our tiers, water and oil. I tend to avoid mucin most of the times because it's not always as relevant when we're trying to simplify things and just get our message across with patients. But I'll explain, we have water and oil in our tear film. We have 30 to 40 oil glands along our upper and lower eyelids. I'll often pull out this BlephEx model that you can see here, which just shows that the meibomian glands are these long vertical tubes. So patients get a sense of what MGD and what blepharitis really are. And I'll tell them, when I was pressing along your eyelids just now, your oils are like butter, and so everyone can visualize that when you're holding this eyelid in your hand and showing, what crusting is, where Demodex can lie. I think that having these teaching tools is so important. And so, so that's what I use to really explain MGD. And then for the aqueous deficient, predominantly aqueous deficient patients, I'll say you have a problem with your water component of your dry eye. And then patients can kind of wrap their minds around that. And then how we can work on increasing their aqueous layer and tailoring our treatments for that. I'll always have a preservative-free artificial tear vial in my pocket because, every patient, they're coming in, a lot of them have tried so many different things for their dry eye already at this point. And they'll be like, yeah, I tried every drop on the shelf, and then I pull out my little preservative-free tear and say, well, do they look like this or are they in a big bottle like the Proparacaine that's in the room, And so everyone knows what their bottle looks like at least. And so just showing that visual, they'll be like, oh no, that may be one I haven't tried, So having some practical things that are really easy to get in the clinic, I find very helpful to educate my patients. And I've kind of come up with my own script because it's just something that I repeat, multiple times throughout the day. But I found that's really useful to have some sort of script in mind. So I make sure I touch all of those points that I really want to get across for my patients. And that's really worked well for me. What's it like in your practice?
Yeah, very, very similar. I like the same approach as far as simplifying. I try not to get into the multifactorial aspect because I don't want to overwhelm the patients. And frankly, I do like your approach of water and oil because I think they understand that. I might actually have to modify my script because I usually talk of the 3 layers of the tear film, and I'm big into using my hands. So you'll see, mucus, water, and oil, and I'll explain that. And I'll explain the function of the oil layer and the function of the water layer. I think that would be helpful to maybe skip out on the mucin layer because, most of our issues are with those top 2. Other things that I like, I have one of those models as well. And I think whenever I bring that out, it has a tendency to scare the patients. And so I rely more on something like this, which is, the meibographer imaging. And I show them where they have their image relative to kind of a standard picture. So then they can actually get a good idea when it comes to, the oil layer, if they have MGD. I can kind of point as a reference. A lot of times I don't even have to say anything. I just say, these are what normal tears look like or normal glands look like. And then here are yours. And oftentimes it's kind of very similar to the old commercial where, here's your brain on drugs, type of thing with the frying egg. You can actually see, here's a normal tear and here's yours. And you don't really even have to say anything. It kind of, says it for itself. A picture's worth 1,000 words. So I do like that approach as well.
Yeah, dry eye, there's just so many nuances to it that it's easy to kind of get into the weeds. And for patients coming in looking for, a solution for this problem, they may not need all of those little, we can think through it, but we really need to simplify it. So I think that that's helpful when you're starting out with any dry eye practice, especially as you'll see as we get into these procedures as well. So, Tom, how do you identify patients in your clinic for these various dry eye treatments and procedures?
Yeah, so let's talk about simplifying. So, there's a lot of things we can do. I think first of all and foremost is to have a symptom questionnaire. And in our practice, we use the speed questionnaire. It's kind of modified. There's typically 3 sections in the real speed questionnaire. I've kind of reduced the top one. And just kind of got to the bottom 2. So my scoring is out of 28, and you can see on a speed questionnaire that the bottom 2 sections add up to 28. And what that does is it kind of identifies patients not only to themselves if they're symptomatic. And so when they come in and they fill out their demographic form, even if they are previous patients, I'll have them fill out a speed questionnaire, which helps to identify and elucidate what their symptoms are. And so that when my technician brings it up in the office or when I see them in the exam room, then they've already heard or they've already read the symptoms and they're already kind of thinking and reflecting upon, okay, over the past week, have I really had issues? Over the past month, how often is it really an issue for me? So they're already in tune and inclined to discuss the ocular surface. Now, I will say that my cutoff on that is usually right around 6 or 8 as kind of like the beginning line. And so if a patient comes in and their symptom questionnaire is right around 6 to 8 in that range, then I'm already thinking about ocular surface issues and what the next step could be. So that being the symptom questionnaire, that's kind of the easy first step. Identifying, clinically, there's some obvious things at the slit lamp. We do a tear breakup time and a tear meniscus evaluation on everybody. And that's something, again, these are things that don't cost anything extra. The ocular surface examination, I'm doing that anyways. The symptom questionnaire, that doesn't cost anything extra. And that gives me a pretty good breakdown as to if there's aqueous deficiency or if there's oil layer deficiency just by doing a quick exam. However, in our office, we also like tools like the Inflamadry, tear lab osmolarity. That gives me a little bit more indication as far as inflammation. Whether it's not only obstruction of the glands or if there's inflammation that goes along with it or inflammation instead. So those tools are important as well. And I like, obviously, Meibography is a great tool for education. Identifying what the patient's goals are is also key. So, sometimes we're limited by, patients who are wearing contact lenses and they're down to maybe 2 or 3 hours a day, and they want to be able to extend the duration of wearing time, or maybe patients are interested in refractive surgery and we want to optimize the surface before we take any measurements and predict the laser algorithm. So I think a lot of it is understanding what the patient's goals are and talking to the patient. And I ask them what their profession is. I ask them what they do for a living or how they spend their days, during the day, if they have a lot of hobbies, because I want to understand, again, what their goals are, what their limitations might be. And one thing I don't do is I don't do a lot of artificial tears. I don't prescribe artificial tears. My feeling is that they're there to see me for ocular surface disease. And so I'm not afraid to kind of jump right into the prescription medications or some of the surface treatments, because I feel like they've probably already exhausted most of the artificial tears, or they're kind of self-treating at that aspect. So, I kind of jump right to that next level of what I can provide that they can't get from just going to the local pharmacy. Does that sound similar to how you treat?
Yeah, really similar. As a cataract surgeon, I find that I just pick up so much dry eye in patients who are coming in for cataract consults. So Speed 2 questionnaires, I also use modified Speed 2 as well. And if I see, a score higher than 10 on Speed 2, then, maybe this is going to turn into a dry eye eval. Maybe we need to address this before we dive into biometry. The thing with Speed 2s, though, as we know, it's so subjective. So someone's 28 could be someone else's score of 10. So I find it really helpful for, the first session, that first visit, first consult. The Speed 2 will be our baseline score. And I repeat it at every follow-up visit to make sure their score is coming down, because it's all relative to that patient, So especially when, we're talking about procedures in clinic, I'll get a Speed 2 score the day before or the day of the procedure, and then get a score after. And even, if the patient, anatomically on their exam, everything looks better. If they're not feeling better, or they're telling me they're not feeling better, I can look at that Speed 2. And a lot of times, even if, if we're getting some small improvement, well, we're making progress. And then I can tell patients, well, actually, I'm really encouraged because it sounds like you're feeling at least better to some degree. We're making some progress here. So using a Speed 2 score as a marker for that specific patient, I've found to be very helpful in my practice. But yeah, otherwise, diagnostics, same sort of thing. I have access to Inflamadry, tear osmolarity as well, but really with fluorescein, with pushing on the lids, with looking for collarettes and Demodex, all those things that anyone can do with the slit lamp and just simple fluorescein. There's so much that we can see, and you don't necessarily need all of these diagnostics or toys to be able to treat dry eye. And so if you're thinking about incorporating these procedures, I want you to realize that you really don't need all of that. A very thorough, focused history, focusing on what the patient's goals are, and a focused slit lamp exam, and those things that don't cost anything, like a speed tube, a fluorescein. That's really all you need to get up and running for any dry eye procedure.
I agree. And as far as the subjective, kind of keeping track of that on a regular basis, I do the same thing, and I like that aspect. But one thing we know about dry eye is that signs and symptoms don't always correlate. And so, sometimes if we do look at the ocular surface and we see a change, I do find that a lot of the objective data collecting, some of the tear labs, some of the inflammatory is key. And so, having the diagnostic tools to give you that objective measurement. So, if Mrs. Jones has, maybe a similar symptom questionnaire, but you see that the glands have improved their functionality using meibomian gland expression, then you can correlate that, yes, functionally we are looking better, and functionally, things are improved. Is that kind of how you handle the diagnostic side?
Yeah, definitely. I mean, we need the subjective and objective. It's nice to have those objective markers to be able to explain the benefit of treatment, why the patient's doing what they're doing, why we're recommending the procedures that we are, and be able to give them some objective feedback because of that mismatch. I mean, between the signs and symptoms of dry eye, that's what makes it a tough disease to treat, that there is that disconnect. It's not glaucoma where, you use a drop and the pressure's down and we know the number's lower and everyone's happy, So that mismatch really makes it so important to have both subjective and objective data. Definitely, I totally agree.
And so speaking of difficulty to treat, so these patients have expectations sometimes. And so I guess my question for you, maybe we could talk a little bit about how to set realistic expectations, especially for the new patient that you haven't met yet, and you're meeting them for the first time. What is your approach? I'll let you maybe answer that first, and then I'll kind of explain maybe my approach, and I'm kind of curious to see if we're on the same page, or maybe we're different, and see if we can maybe banter a little bit about that.
Yeah, there's a lot of different ways to have these discussions with patients, and you kind of figure out what works best in your practice, with your population. But what I want patients to know when I'm meeting them for the first time is that we're going to work on this together. I'll tell patients there is no one cure. There's no one thing I can do and change your dry eye right now. There's no one magic cure for everybody that's going to work for everybody. And so it will take some work on their end as well. A lot of times with these, it's a chronic condition, as we know, and so it needs a chronic treatment. But our goal is that it's really not affecting their day-to-day, that they're able to do everything that they want to do and they're comfortable. That dry eye is not a limiting disease. It's something that we can treat and help them through and work on it together, and I want them, as I discussed earlier on, I think that education piece is so important because I want them to know why we're doing what we're doing and tailoring the treatment to their exact cause of dryness. And so I think when they know why they're doing something, that's when compliance improves. And then using those tools, for example, I have a dry eye sheet that I give every patient in my clinic where I check off everything that I'm recommending for them, and I'll tell them at the beginning of the visit, just so you know, everything I'm going to tell you is already written out. I'm going to give you a sheet at the end, so we're going to talk through it, but don't worry, some patients I'll have take out their notebook and frantically start writing. I'm like, let's just talk, let me tell you what I'm seeing. And I'm going to get it all typed out for you. You'll have everything you need at the end of the appointment. But so making sure they're educated, making sure they know why I'm recommending what I'm recommending, which will improve their compliance, and simplifying, and just making sure that they know, a lot of patients are looking for a quick cure. There are a lot of things that we can cure. Once the cataract is gone, it's gone. And that's, it's different than dry eye. There is no cure. And some patients are really surprised to hear that there is nothing that we can do to cure them of this disease. And so, so that's kind of how I approach it. What do you find useful in your practice?
Yeah, I think using the term, no cure, I think that is
Yeah.
very important. And I would disagree. I don't think a lot of patients are that way. I think every patient is that way, that they want a cure. And so one of the things that I guess I'm not afraid to tell patients is kind of a percentage of what I expect them to be improved. And so, whether it's a pharmaceutical or if it's a procedure, I'll tell them that, let's say, for example, a patient has MGD with inflammation. I'll tell them, okay, we're going to, do a procedure like tear care, for example. And I expect by opening up your glands, we're going to get, roughly 50 to 60% improvement just from that. But then in order to kind of move forward, we may need to also add an anti-inflammatory to get another 20, 30, 40%. And so it kind of sets the expectation, and I document that. So that way, when they come in for their follow-up visit and they're like, oh, well, this is still here. It's like, okay, you're right, Mrs. Jones, we talked last time that this would be 60%, roughly speaking, and then that there's still other things to do. And again, I get back into the hand thing and I say, okay, it's like building a house. And so, our first treatment, what we're doing is we're kind of clearing the land and maybe setting the foundation, pouring the footers, and maybe even getting that first level set for you. Now some people are happy with a 1-story building and they can, have the ranch and it's beautiful and it's great, but other people want a 2-story structure or a 4-story structure. And so some people need more than 1 or 2 or even 3 different therapies in order to get to the point where they're less symptomatic, where they're happy, where their lifestyle can be, what they want it to be, and their limitations are removed. So I kind of get back into the, give them an analogy that they can understand, but then also help them to understand that they're part of the process. And so if they have 60% improvement, they may feel perfectly back to normal, and they've never been better than 60% their entire life. And so they may have one treatment and with a procedure or medication and feel absolutely resolved. And then maybe seasonality, occurs. So in the summertime, they're great, but in the wintertime here in Cleveland, in the wintertime, it may get worse. And so we might need to add that second story, during the wintertime. So I try and bring them into the process and help them understand what they can expect. And reiterate that dry eye is a chronic condition and that it didn't happen overnight. And so it's not going to go away overnight. And so regardless of the treatments, it's a treatment as opposed to a cure. So I agree with your approach. How would you go about, we talk about simplifying, I use the house analogy, and I guess, how would you go about simplifying it and kind of going through the treatment regimen? You mentioned the worksheet. So that could be kind of intimidating to get a whole worksheet that lists 20 different things in there. How do you simplify that?
Well, I check them off. I say ignore everything I didn't check off, because then it will be very overwhelming. But a lot of it really depends on the patient's goals. So some patients are perfectly happy with starting with warm compresses and, hypochlor scrubs and starting out kind of conservatively. Some patients, are honest with me up front and they're like, I don't know if I can, commit that time. And then I try to offer things that can make it easier, like a heated eye mask or a plug-in mask. But some patients still want to see if there's something they can do in order to just accelerate their progress. So that in particular is where I really find the dry eye procedures to be helpful. So if I can do a thermal meibomian gland expression in the office, I know I can get past some of those blockages that it would take them a while to get past. Or if I can do, a BlephEx in the office and just clear the biofilms and help with their Demodex, help with that severe crusting that they have, we can help kind of reset things sooner and just jumpstart their progress. So that's where I really find dry eye procedures to be helpful in my practice. And so on all my sheets, I kind of have the conservative, have the medication options, the oral options, the lid hygiene, and then I have those procedures on there too, as an option too. So patients hear about these procedures early on and really just tailor which things I offer to the patient, based on their goals. So for example, for inflammation, my kind of script, what I, say for that is there are 3 different ways to treat inflammation. We have drops, we have pills, and we have procedures. And a lot of it depends on what you're up for. Some patients may not want to take oral doxycycline, may be concerned about longer term antibiotics. Some patients may, just have a lot of sensitivities, not tolerate a drop option, and they may be looking for more of a procedural based option. And so that's really how I try to simplify, not throw the whole kitchen sink at patients, but based on their goals, just try to simplify and tailor it to their needs, and also to what they're kind of up for, and just have that discussion with them up front.
Yeah, I agree with the procedure aspect too, because that also does help with compliance. I mean, for those patients who are interested in the procedure, it does accelerate it. And in fact, after I do a procedure, whether it's a BluffX or, you know, my Meibomian expression, what I'll tell the patient is, you know, believe it or not, that was the easy part. Now, the hard part is up to you as far as ensuring compliance, you know, and we say, okay, now you need to make sure you do the hot compresses. You need to make sure that you take your omega-3s and those aspects, because that helps to kind of, again, bring them into the process. So that it's not just me doing a procedure and then expecting a cure. This is a condition that we're treating, and we're minimizing the effects.
Definitely.
So speaking of patients, why don't we do a couple cases here? These are probably, I have a case, and I think Mina has a case where we can just talk about some patients that we normally see. And frankly, this patient is probably a patient that, you know, I'll see maybe, you know, 2 or 3 times a day. But we're dealing, you know, with a 62-year-old female. She's a nurse in the healthcare field, and she spends a lot of time on the you know, screen, as you can imagine, with charting and EHR these days, and kind of going through that. You're spending in an 8-hour day probably 7 hours and 45 minutes on screens, and obviously through the day she has to wear the mask, because, you know, in the healthcare field we're all wearing masks, and so, you know, for the full 8 hours as well. She's a history of rosacea, and she wore contact lenses in the past, but is not quite able to wear them as often, primarily because of discomfort and just kind of always being blurry with the contact lens. So she's using artificial tears, but having to use them quite frequently at work. And oftentimes she just, you know, takes the contacts out because she doesn't like to have to put the contact lenses in over and over. And so that's kind of her background. Now, clinically, you know, when you look under the slit lamp, you see, you know, mild telangiectatic vessels. She does have a little bit of crusting at the base of lashes, and you know, her meibomian glands are definitely blocked. That buttery formation that Mina described before. I use the term toothpaste to patients, but still, you know, it's that thickened meibum. There's definitely some SPK inferiorly, and you know, even through some of her vision. Centrally, so it's just kind of like a diffuse SPK. Her tear breakup time is really low at 4 seconds. Actually, kind of even surprised it was that long, but it's at 4 seconds. And her lids were actually, you know, had good lid apposition, so she didn't have any kind of lid lag ophthalmos or anything like that, where, you know, we were thinking of an incomplete blink, and certainly with the diffuse SPK, you know, that kind of also lends to a decreased tear breakup time as to maybe an inferior exposure. Positive MMP9, so, you know, obviously she's got some inflammation as well. Tear osmolarity high, you know, above the 300 marker, 309 marker, so it's 321. So we're dealing with, you know, obviously patient here who's got MGD as well as inflammation on the surface. So, you know, maybe if we could just role play here, Mina, I'll ask you to be the patient. You know, she's quite a bit older than you, but at the same time, I think you probably see these patients as well, so you can relate. So yeah, exactly. So Mina, I'm just gonna let you know, basically you have 3 layers to your tear film, and this is how I do it. And certainly I listened to a colleague recently who described 2 layers, who I have a lot of respect for. So let's talk about 2 layers of your tear film. There's the water layer and the oil layer. And in your case, you have issues with your oil layer. Now the function of the oil is to provide a nice smooth glide every time you blink, as well as to protect that water layer below from evaporating. And so in your case, you don't have a good oil layer. So the tear layer below has a tendency to evaporate, and that's why your contacts can be uncomfortable. And so when you're staring at the screen, it kind of comes and goes blurriness on you, because that oil layer is not protecting the tear film. And then when you blink, it's not wiping it. It's not a smooth hinge. It's actually kind of like a creaky hinge, kind of rubbing that surface. So it could be irritating and uncomfortable. And so that's the problem as far as the glands. And how do I know that that's an issue? Your oil layer is the issue, because I counted the glands that you have, and I didn't actually add that in the chart, but your meibomian glands, which are the glands where the oil is made in the upper and lower eyelids, we like to see about 10 to 12 of the 20 glands actually functioning. And in your case, you only had 4 glands. And so as a result of that, you're not pumping out the oil, you're not improving the surface. And so There is a fix for that. There's a treatment that we have in the office, and it's a procedure. In my office, we use TearCare, and what it is a device that we put on the eyelids for 15 minutes. We heat up the glands, soften up the material inside, and then after 15 minutes, I come in and express those glands. It kind of feels like you're squeezing the skin between your thumb and your first finger. It's a little awkward feeling, but it's not painful. And that's one way to open up the glands. Now, in addition to the glands being kind of encrusted and full of like a toothpaste material, what happens is it kind of accumulates at the base of your lashes. And that can be an environment for some microorganisms that live along those eyelids to hyperproliferate or kind of, grow more than they should. And there's another procedure that we'd also encourage you to do today, and that's what we call BlephX. And what that does is it's a cleansing, and it's a wiping of that biofilm, removal of all that debris. And so the procedures that I recommend is the BlephX today first. And the reason we do that first is kind of remove the keratinization, remove that thickened structure on the surface, and clean up the lids and lashes. And then also the clearance of the TearCare subsequent to that. Beyond that, that's the treatment that we'll do today. And then beyond that, there's some maintenance things that you can do. The first thing would be a hot compress. And we typically recommend 3 to 5 minutes of heat with a mask of some sort on the eyes. And that keeps the glands open. Once we open them today, we want to keep them open to maintain their function. After we keep them open with the heat, we'll have you use a lid scrub. You could use baby shampoo, or you can use these lid wipes that we have here, or you can use a hypochlorous spray, which we also have here as well. And then we're going to recommend that you blink, because every time you blink, there's little tiny muscles, the rhyolin muscles, that squeeze those glands and get them flowing, as well as omega-3s. Now, don't worry, there's a lot of information we covered today. I do have a sheet here, which will explain everything for you. Do you have any questions today?
Yeah, I don't know if I have enough time. You're telling me I have to do this, 3 to 5 minutes every night. How long do I have to do this for?
That's a great question. I'm glad you asked that. So the treatment today is going to get you fast tracked so that we can open up the glands and get you an improvement right away. And then the issue is to basically maintain the glands. So I would tell you want to do it as long as you want to keep those glands open. So it's kind of like when you go to the dentist and you get a cavity filled and the dentist tells you need to brush your teeth every day. Well, how long do you brush your teeth? Well, I guess the answer is as long as you want to keep your teeth. And so I would tell you, we open up the glands today. And so you want to keep those glands open as long as you can. And that's why the 3 to 5 minutes of heat will maintain that best possible.
So I have to do this forever? There's not a cure for this? There's nothing you can give me to just get rid of this?
I wish there was, Mina, and dry eyes is a chronic condition. It's something that didn't take overnight to get to this point. It's taken you 62 years to get to this point, and so it's not going to. Now, fortunately, I don't think we're going to have to wait 62 years for you to get some resolution, because we have the procedures today. But I do think that this is going to be something that you're going to be battling for the rest of your life. And so by doing the procedures, by doing the maintenance, we can help to ensure that we give you a good quality of life, and you can wear your contact lenses longer, and you can enjoy the screen time a little bit more so. But I do think that this is going to be something that you're going to be doing chronically from here on out.
Okay, kind of like brushing my teeth.
Exactly, just like brushing your teeth. Now, and I will tell you that in your case, it's like building a house. So, with the procedures and kind of cleansing everything today, that's, cleaning out the lot and digging the footers and building that first surface. And then when we add the mask and we add the lid scrubs and we add the omega-3s, we're going to have a nice 3 or 4 story structure that you're going to be real comfortable with and you're going to be real happy living in.
Great. Yeah, sounds good. Yeah, let's do the procedure today.
Very good. Very good. And I wish it was that easy with every patient. But,
I tried to give you a couple objections there,
You did give me a couple. You did give me a couple objections, and I appreciate that. And then certainly what I would do would be, as a follow-up for this particular patient, is after the procedures, after their home maintenance, I would bring them back to the office in about 8 weeks. And depending on a lot of the lifestyle questions and things like that, we may have added a pharmaceutical option the day of the procedure, or we may wait that 8 week window, and then at that point we can continue to build on it. It just depends on patient, again, their limitations, their goals, their desires. If they're, impatient, they want to get things done, we may have started it right away. If they want to hold off because they're worried about their prior authorizations and insurance and all that, then they may want to wait on that. So excellent.
No, that was great. I mean, your script makes a lot of sense, very organized. I think patients will be able to follow that well. Having some printout, something for them to take home. And it sounds like in your office, you also have these things available for them to buy, which also really streamlines and will only improve compliance if they can go home with something in their hands that they know they know how to use. So
yeah, and I wasn't sold on having the store in the office at first, just because I didn't want to have a lot of inventory. I didn't want to have out, but you're exactly right. The compliance and the convenience for patients, they come in asking for it, and so it's really helpful. And the hot compresses that we have in the office, I don't think they're anything magical about the ones we have, but they come in and they want to buy that because they're there and they know that it's easy and it's convenient. So that's a very good point.
Yeah, it just gets rid of one barrier to them getting it. And some of my older patients, they may not shop online, or with supply chain issues, they may have trouble finding some of these products, at their local drugstore. So yeah, I think that's really helpful.
Yeah.
So we have another case that I'm going to talk through with Thomas, the patient this time, of a patient that, again, another one that I would see multiple times a day in my clinic, a 55-year-old male who's an engineer, a lot of screen time. He tells me he has 3 different screens up in his home office, still working from home, but just, it seems like the screen time has gotten even worse since he's working from home. The eyes just are tired. They get worse as the day goes on. By the time it's the end of the day, he sits in bed to watch TV. The vision's just blurry. It fluctuates. It feels like he has to blink so many times to clear his vision. And on slit lamp exam, this patient has trace lid telangiectasias, trace crusting at the base of his lashes, very turbid, that butter or toothpaste, like MGD there that you can see in the picture here. 1+ inferior SPK, instant tear breakup time, but good lid apposition to the globe. I'm not concerned about floppy, some mild lid laxity, so maybe some floppy lids. Maybe I could ask about that those OSA risk factors. MMP9, he's positive, and he has increased tear osmolarity as well, so positive for inflammation in his tear film. And so for a patient like this, I'd get into my spiel, Tom, we have 2 main things in our natural tear film. We have water and we have oil. You have a problem with your oil component. I'm pressing along your lids, your oils are butter. So as you know, oil lasts a lot longer than water. If you have oil and water, the oil is going to linger, the water just evaporates really quickly. So it's really this oil deficiency. Your tears just evaporate right away. You start out with a normal amount of tears in the morning. As the day goes on, your eyes are open and you're just evaporating. When you're looking at a screen all day, as we all do, as I do every day too, I get it. We're focusing on the screen, we blink less, we blink about 50% less. When you blink less, you evaporate more. A blink is your eye's chance to re-wet your surface, to re-lubricate your surface. So looking at a screen is a huge risk factor for you to be drying out as the day goes on. By the time the day goes on, you're sitting watching TV, you've evaporated through all of your tear film, you have no tears left on your surface, and so your vision's blurry. You need nice, healthy tears in order to see well. And so your tears just evaporate so quick, you're out of them by the end of the day. So I'm not surprised it's really tough when you're watching TV. So I'm going to tailor and give you a few options for things that we can do to get your oils back into that liquid state. A lot of it depends on what you're up for. I do have a few things I can offer you even today in clinic, just help jumpstart things. There are a few basic things that you can use and recommend you use at home, just as kind of a maintenance routine. If you're up for it, we do have a procedure in the clinic where we apply these little stickers to the upper and lower eyelids. They heat up to 115 degrees for 15 minutes. Patients find it really comfortable. I've even had a few patients fall asleep during the procedure. They're so comfortable. But then I go in with a little eyelid expressor tool, just get those oil glands out, get past some of those blockages, and get kind of jumpstart getting these oils turned from butter to oil. And so if you're up for it, we can even do that today. And then just like when you go to the dentist and get a deep cleaning, if we're deep cleaning these oil glands today, I want to make sure we maintain it. So there are some at-home heating masks. There's a plug-in one that I really like that can just kind of help maintain what we do today. Because I want to make sure that we get past these blockages and keep you comfortable. And it can take a while, you know, to get to that point, but we're going to start working on it today together. And so there are some eyelash cleaning solutions too that I'm going to recommend for you. I'll give you these on the sheet here too that are just over the counter. And you can spray these right along the lashes themselves to help just clear away biofilms and clear away some of that crusting that you have there too. There are some artificial tears that you may want to keep next to you when you're on the screen all day. You know, remembering to blink is really important because you're not blinking enough with all that screen time. And some of my patients find it helpful to put in one of these little vial preservative-free artificial tears while they're at the screen too. So it may not be a bad idea to have those around and just by your office, your home office. Having a humidifier in your house can also help too, especially in the winter. So just in getting rid of that environmental dryness with the heat blasting. And so do you have any questions, and what are you kind of up for? Do you want to think about a procedure today, or do you want to start with some of this home care?
Yeah, you know, we have a humidifier. We just did the whole house humidifier thing. So yeah, I feel like we already are doing that.
Excellent.
Yeah, I'm not really big into procedures. I don't like anybody like coming close to my eyes. It just makes me real kind of nervous. And plus I don't have a driver today. And so isn't there any kind of like, you know, just drop that you can give me? I mean, I just, you know, if there's a drop that I can take like, you know, today, tomorrow, I just want to go away. But, you know, otherwise I don't have a driver with me today.
Yeah, good question. So the issue is it's really that your oil glands are obstructed. So, you know, drops can help to some degree. There are some prescription drops that we can start for you too. But the main thing we really need to work on is just these oil glands being so obstructed for you. So, and for this procedure, it is something that you don't need a driver for. You know, after the procedure, I rinse your eyes out with some lubricants. Your vision will be the same as it was before the procedure. We can always schedule you if you're more comfortable on another day, so you can have a driver with you. But my patients personally find it, you know, very comfortable, and the vast majority of patients do drive right after the procedure itself. So, but if you'd like to start with a drop route, that's totally fine. The prescription drops are great. They help you make more tears. They can battle lid inflammation as well. The downside, sometimes there are insurance coverage issues, and they can take a while to kick in. So even the ones that are a little quicker can take about 4 weeks to kick in, and some of the longer acting ones can really take even up to 6 months to kick in. So there's really, unfortunately, no quick solution here. It's going to take some homework, some maintenance, because there is no cure for dry eye. But yeah, definitely a few options. If you feel more comfortable coming back another day, we can start with the drop route.
Yeah, I just know myself, like, I don't want this to go on forever. It's so frustrating. I have a hard time at work with the screens. You know, I really want to get this taken care of today, you know, like now, like I wanted it fixed yesterday. It's so frustrating. And, you know, but I've just, you know, I'm just not sure about the, you know, you touching my eye. How long does it take where you're like squeezing me type of, like, how long is that going to be?
Oh, it's just a little bit of pressure. So there's nothing sharp, no sharp instruments at all near your eyes. It's just basically the oils are already melted from those applicators along the lids. So I'm just pressing along the lids with this blunt little tool. It's like it's a massage along the lids that I'm really doing. So patients are really comfortable. We give you a numbing drop before, so you may feel a little pressure, but yeah, really not bad. Just a way to jumpstart the routine if you're up for it.
Hey, I'm up for that. He said massage, I'm ready. So sign me up. Let's do it now.
That's good.
That was great. That was excellent. No, that was fantastic. So I think we're coming up close to running some questions here. So maybe we can
make sure we have enough time to answer everyone's questions, definitely. But hopefully those dialogues, those scripts were helpful for how to really get these things up off the ground and running for the procedures. Damon, do you have any questions come through?
Yeah, not surprisingly. Great job, guys. Mina, Tom, I love the role playing for sure. And we had a comment from Shannon. Mina, you look fabulous for 62. So
thank you. Thank you very much.
I think the role playing is really critical. We have a couple, specific questions about different technologies, medications, but I want to get to a question about accelerating in-office treatment. And, curious, what does the conversation sound like with the patients that do not have symptoms, but test for dry eye disease? Your workup shows they have some signs of dry eye or MGD, but they're asymptomatic. If one of you guys want to role play that, Mina can be the patient, Tom can be the doc, or vice versa, for the asymptomatic, maybe skeptical patient.
Sure, absolutely. Yeah. And I would just say that, so there's maybe a couple different patients that we would see. So there's maybe a neurotrophic patient who's so dry that they don't feel the sensations. And in those particular patients, I would actually explain to them that much like if your arm's falling asleep, you don't feel anything. And then as it's kind of waking up, you get that prickly sensation. So for those particular patients, as we're kind of stimulating it, we're repairing the surface, we get that foundation going and we kind of, start building upon it. And as we start building, they may actually start to feel a little more sensation, and it may be a little bit more uncomfortable as they get over that hump until they can get into a more healthy situation. For the other patients who, maybe they have a huge pain tolerance and they're not necessarily, that in line with it, we talk more about fluctuating vision. That's actually the leading symptom that I hear, is that transient blurred vision. So, I try and find out really if they are, having symptoms, maybe, they're just not thinking that it's, or they're not equating it with dry eyes. But I also, if they deny all those types of things, then, like, for example, maybe it's a perioperative patient who's getting ready to go into surgery, in the next couple of weeks, we'll talk about maximizing the tear film so that we can optimize the calculations for the premium lens or refractive surgery. So, there's some different aspects where you have to kind of approach, those maybe 3 different patients that may not be reporting symptoms. How about you, Mina? Do you have anything extra?
Yeah, definitely in my surgical practice, it comes up all the time.
Right.
I do a lot of premium multifocal toric lenses. And, as we know, having a pristine ocular surface is so important for biometry and also for post-operative comfort. And so I'll oftentimes rely on my corneal topography imaging to help guide those conversations. If they have a lot of SPK, if the surface is really rough, it's going to show up in my topo. I'm going to have a lot of just inconsistency between my Ks when I'm checking them in multiple different ways. Everything's going to be inconsistent. And so I can show a patient a corneal topography picture. I explain it like a land map, like blue is flat, green's a little bit more elevated like land. When you get into green and orange, yellow, orange, and red, it's steep like a mountain range. And I'll tell them, look, this is your central 3 millimeters. That's what you're looking through. And it's like a rainbow. It's so irregular. So I really don't know what type of lens to choose for you, because our measurements are all over the place. And I want this to be a surgery I do once for you. We hit our target. We're right on target. You're happy. We get you to where we want. And right now, I just don't have reliable enough measurements to do it. So again, using that objective data, my biography there's nothing, more convincing than seeing atrophic meibomian glands on my biography. Patients see that and they get it right away. And I find topography is also super helpful along those same realms, because it comes up all the time. Patients are like, well, my optometrist just said I had cataracts. What is this whole other, the whole visit change? And so that's when I bring up the topo and find that to be really helpful in my practice.
So takeaways for me there is that dry eye doesn't always mean dry, right? It could be fluctuating vision. It could mean that it's going to make it difficult for you to do your preoperative measurements and have a great surgical outcome. And that's obviously going to be news to many of our patients in this space. We had a question about what particular masks or plug-in masks are you guys using for maintenance therapy?
So I have a local source. I have a woman who actually makes the masks for me. And so it's much like a Bruder mask, but it has a separate cover. And so, the inside, I believe she's using some form of rice, substrate, and then, kind of packages it and has a little pattern. And then she creates a separate pattern for it based on a different material. And so different designs, it's more cosmetic, that aspect. And the patients can then take the cover off. Unlike, maybe some of the commercially available ones out there now where you don't have a cover to them. But she does that for me. And then I also use another commercial available product from Wizard Research, which is a plugin. And we found for some reason I have some patients who don't have microwaves, which I thought everybody at this point.
More than you think. Yeah, definitely.
Yeah, it does come up more often. And it's certainly like those patients who travel a lot, they use it as a plugin. And those have a tendency to work well as well.
And Mina, what are you using for the plugin?
For the plugin, there's one actually on the Hammaker-Schlemmer website. It's called the Ideal Dry Eye Mask. It's been tested by ophthalmologists. The low setting is hot enough to melt the oils. It has a timer on it. It has an automatic shutoff function on it. So it kind of overcomes all those barriers to compliance. So that's the one on my sheet right now that patients I've just gotten great feedback from it, from patients on it. So that's the one lately that I've been recommending.
Mina, Tom, a lot of great questions here. You may want to jump into the chat. There's all sorts of things people want to know about, but I do need to wrap up this session. Our next session is going to start at 15 minutes after the hour. Your raffle code bonus for this session, actually, Mina says she doesn't really care so much about it, but Mucin is actually going to be your raffle code for this section, ironically enough. So thanks again, Mina.
Mucin's important. Mucin's important, but yes.
Thanks, Tom. Great session. I'll see you guys again soon.
Thank you.
Thank you so much, Damon. Thank you.